Professor Greg Rubin. I'm the Professor of General Practice at Durham University, and I'm also the Clinical Lead for Cancer at the Royal College of GPs, part funded by Cancer Research UK. And you have my written evidence, but if I could summarise my thoughts, I think that we should consider the role of GPs in pancreatic cancer diagnosis, what scope there is for improvement in that process, and what the implications of any change might be. I think, as far as the role of GPs is concerned, I think it's important to understand that GPs do not diagnose pancreatic cancer. What they do is differentiate those people who need further investigation from those who don't. In terms of the scope for improvement, and there's quite a lot of focus on the potential for tests, first of all, GPs always consider what symptoms a patient presents with, and the problem with pancreatic cancer is that its symptom signature, there are no characteristic symptoms, and therefore it has a vague symptom signature. That makes it difficult to diagnose on the basis of symptoms alone, and therefore we have to consider what tests might be appropriate. And in undertaking tests, what we're looking for are tests that are very good at ruling out the condition in primary care. And such tests are not universally available to us at present. Perhaps the best test for pancreatic cancer is a CT scan. That's almost always a test ordered by specialists and undertaken in specialist units. We also need to think about tests that will help to exclude other possible causes, or can be quite general and include serious disease in a more general sense. And some tests do exist of that sort, but again, they are not specific for pancreatic cancer. We should also consider referral pathways, and we have a well-established urgent referral pathway for cancer. But we don't have, of course, that pathway requires you to think that it might be pancreatic cancer before you make the referral. What exists but is not well known and not well organised is a pathway for people where you suspect there is a cancer and you don't know where that might be. This is a cancer of unknown primary. Such pathways should exist. They are not well known or well understood in most trusts. An alternative model, which we see in some countries, is one where a facility for investigation of people with non-specific but worrying symptoms exists. And such pathways are now being developed in Denmark and something similar in Canada. Lastly, I'd like to touch on the implications of change, and the resource implications are, of course, the most important consideration. To reduce the threshold for investigation needs quite a wide acceptance amongst the medical and commissioning fraternity and the provider fraternity. I think we don't know what the cost effectiveness would be of modifying thresholds for investigation. Save to say that as things stand, I think GPs are expected to have a greater degree of certainty before they direct patients down urgent referral pathways than is actually realistic. And therefore, lowering the threshold seems to be the most appropriate route to go down for pancreatic cancer. I think, lastly, that more general interventions for general practice, such as better training or incentivisation through quality and outcomes framework, are probably not appropriate for pancreatic cancer exclusively, but better directed at the diagnosis of cancer in general. Thank you.
Professor Hamilton, do you want to...
Thank you. William Hamilton. I'm also a GP, like everyone on this bench, but my main job is as Professor of Primary Care Diagnostics in the University of Exeter. And within that, my main research programme has been identifying and quantifying, so putting numbers on the symptoms that underpin cancer in general practice, not just pancreatic cancer, across a wide range of cancers. And one of the main outputs of that is risk assessment tools, coloured charts, describing the symptoms of cancer and giving a figure for them, for GPs to use. I don't want to steal Rosie's thunder. She'll be describing what happens next with risk assessment tools. So that's where I come from. I have a second hat, which I wear slightly uncomfortably today, in that I am the clinical lead on the revision of the cancer referral guidelines within NICE. And we will be reporting in, I think, 2015. And within this guidance, we will be looking at each cancer site one by one and providing guidance to GPs for best practice in terms of diagnosing cancer. So Greg's point about thresholds will clearly be germane to that. We've not looked at pancreas yet within NICE, so I'm not going to be able to give away any secrets, even if I were allowed to.
We can give you some pointers.
You can force it. I thought you could probably force me to, but you're not going to get anywhere. I'd want to reflect for a minute on Greg's point. Pancreatic cancer diagnosis, and his point that we don't diagnose, we select, is correct, but it's difficult. It really is difficult, because the symptoms are so common and so insidious and so non-specific early on. And in general practice, it is much more easy to look for alternative diagnoses that are easy to treat. And so we will think of the stomach first, we will think of the colon first. It's just second nature. They're more likely. Pancreatic cancer is jolly rare. So I will see one if I were full-timer, perhaps every 5 years. So, understandably, we go off on what transpires to be the wrong direction. And the worst is, of course, it's not just the wrong direction once, it's often twice or thrice. So the poor patient is bounced back and forth from various hospital specialties before the eventual diagnosis emerges. Which brings up the question of GP ignorance. In my submission to your group, I said perhaps slightly too strongly, GPs I don't think are ignorant of the symptoms of pancreatic cancer. I think it is more they don't use their knowledge of the symptoms of pancreatic cancer because they're using their knowledge of symptoms of other diseases. So we know it's a possibility, but it's so subliminal. We go ahead and do something else. And that pertains to general practice as a whole, of course. One symptom I think does require a bit of amplification, and that's the symptom of jaundice. Jaundice is well recognised as a symptom of pancreatic cancer, and I think nearly all GPs would identify that. What we do have is patchy distribution in the NHS of jaundice pathways. Some of them, as Greg has hinted, are super. There's one in Bristol which is marvellous with an enthusiastic gastroenterologist. The one in my place, Devon, is hopeless, simply because there's no one pulling themselves together to say all jaundice patients should go this way, that way, and a smooth route towards diagnosis. So that's clearly one area that your group may want to address. The other issue, I don't want to repeat Greg too much, is investigations. We don't have access to the prime investigation, CTE, abdomen. There's a very small number of GPs do. So we're left with the easy access, not terribly good tests. And ultrasound of the abdomen is used frequently. It's available to GPs. The waiting times aren't too bad. It may, if you're lucky, say the pancreas looks dodgy, but I can't go any further. And then that's okay, because then you can move forward and go and get the CT abdomen. But it's an imperfect test, but it's probably better than no test. So GPs use it quite a bit. I just want to finish with one other question, which again I'm not trying to change your agenda, but I think we shouldn't get totally focused on mortality. Early diagnosis has, in theory, an advantage in saving lives, and that's why we're here, and that's why what I've been doing for the last 15 years. We shouldn't forget the morbidity side of it. Receiving a diagnosis of cancer late is awful, and even if perhaps secretly I know it may not have made any difference to your chance of survival, that feeling that something could have been done is real. The psychological morbidity of late diagnosis is real. And it may be that would be one of the major gains in early diagnosis of pancreatic and any other cancer. I'm not saying mortality gains are to be ignored, but I think our first win will be in morbidity gains, particularly my psychological morbidity.
I'm Dr. Rosie Loftus. I've been a partner in a GP practice in Kent for over 20 years, and I work for Macmillan Cancer Support as their lead GP advisor. Just before I go on to talk about the specific thing that Willie can't wait to hear more about, I just wanted to reiterate my support for access to CT scanning. 50% of pancreatic cancer patients are diagnosed through A&E. And it's a no-brainer to know that people who are diagnosed through A&E are going to have worse outcomes. And as Willie said, it's not just about being diagnosed early so you can have the treatment, but actually when GPs were asked why they thought pancreatic cancer should be diagnosed early, 80% of them more felt it should be diagnosed early to be able to deliver support to people than actually felt it needed to be diagnosed early for treatment. But I think it's about getting the right test for the right patient at the right time. Presently, a doctor who has probably had, no disrespect to my colleagues, but may have had 2 years medical experience can request a CT scan for a patient in hospital where I can't. And it may well be that actually I can set the sieve with smaller holes than they can. Not suggesting one's better than the other, but that doesn't seem logical to me. So if we're going to try and reverse the speed of diagnosis for pancreatic cancer patients, we need to look at the investigations, but in a sensible, planned, structured way. I think many of patients also who go to general practice, many people now are operating at 3 strikes and you're in, is a kind of a simple message. If somebody comes to see us who doesn't normally come to see us and they've been 3 times, we've not been able to help them with their problem or move them on, then we would be considering that we need someone else to help us with that. And also just in terms of GP education, I think GPs are very aware of the symptoms. Sometimes it feels like you can't do an awful lot in terms of clinical medical things for someone when they're diagnosed with pancreatic cancer, but there's a lot of support you can give. But Macmillan Cancer Support is doing a general cancer education day for GPs, and you'll be reassured to know that there is a session on pancreatic cancer in that course. And by the end of the next couple of weeks, we will have reached 7% of practices with that update. So moving on, to the decision support tool that Macmillan Cancer Support is presently working on. We've heard about Willie's work, the huge amount of work that he's done, basically retrospectively looking through patients' notes to see what symptoms they had prior to being diagnosed with cancer. So building on Willie's work and the colour-coded paper chart that was used by general practice, and also some work done by Professor Julia Lipsley-Cox, who's also developed some risk algorithms, what Macmillan Cancer Support has done, we've been commissioned by the Department of Health to actually convert that into software. And we did a very small pilot of this initially with 60 practices, and it was based on the outcomes of that pilot that we've continued to our wider pilot. We're working with a company called BMJ Informatica, who are a third-party software supplier to GP clinical systems. And the reason that we think that actually getting it into software is useful is that actually it will integrate into the GP's standard workflow. So a prompt will come up without the GP even needing to do any extra activity. It uses the information that's stored in the computer system from retrospective consultations. So for the patients who have been recurrently coming to the GP with those things that maybe the dots didn't get joined, the computer will do it for you. And obviously if we can integrate it into software, then the potential for scalability and mass rollout is quite significant. The tool itself works in 3 ways. So, as I said, it will retrospectively look at consultations from the previous 6 months. And somebody may then be coming to see the GP, not because they've still got those problems, but they've just come for a routine BP check. But actually, if a risk has been calculated from that retrospective tool that is 2% or greater, a prompt will flag up as the patient comes in to see the GP. The second arm of the tool is that you can draw up a symptom checker, so that all the symptoms that we've been talking about are pre-populated and the GP clicks to say whether somebody's got that symptom or not. If the patient had attended in the previous 6 months, those boxes would already be pre-populated, and so you'd know that this is the second time somebody's coming. And it will calculate you a risk score during that consultation. The third facet of the tool is a persistent background audit, which can basically risk stratify a whole practice population into high, medium, and low risk of cancer, and then also drill down into specific cancers. So a practice could be routinely looking at those and thinking, Mrs. Jones or Crikey must look at her notes. What is it that's making that score? Is there something that I need to be doing? Even if indeed that patient hadn't consulted the GP. So the pilot started in March of this year, which of course was a very timely, 1 month ahead of huge transitional changes. And with that, transitional changes in IT supply and development as well. But we've got 500 practices so far on board. The practice was set to run until August due to some, whenever you're using computer and NHS in the same sentence, the two are not usually in a happy relationship. So there have been some issues in terms of getting software uploaded, but we're there now with 90% of the practices. The feedback we're getting so far is very positive. Over 69, so 69% of practices are saying this is easy to use, very easy to use or moderately. And in 50% of cases where the symptom checker has been used, individual practitioners are saying that influenced their decisions. So we've got small numbers. With anything in general practice, GPs have got busy lives. We've got 10-minute consultations in which we're trying to do absolutely everything. So our challenge now that we've got it up and running in 500 practices is to remind them it's there in terms of particular symptom checker so that they will use it.
My name is Dr. Stephen Large, and I'm a recently retired GP from Banbury. Sorry about my glasses, they broke on the tube this morning. I see my role this morning to be to represent the normal GP with no specialist interest, doing 2 surgeries a day with maybe 40 face-to-face consultations. One of the GP's challenges is to be on the lookout constantly for the possibility of a newly presenting rare disorder, particularly where early intervention could save life, amongst all the more routine consultations that make up his or her day. And pancreatic cancer falls into this category. In my 32 years as a GP, I can recall 6 patients with pancreatic cancer. And I made the diagnosis in 2 only, but in both cases it took a long time. Pancreatic cancer, as it's been said, is particularly challenging to diagnose because the presenting symptoms can be very common and non-specific. Initially, a sufferer might complain of little more than fatigue, nausea and backache. Sorry if some of this is repetitive, but I think it's helpful. It may take a few consultations over a few weeks before the GP decides that there could be serious disease. And the doctor's index of suspicion with almost all cancers can be raised or lowered with the help of a simple blood test or X-ray, but not with pancreatic cancer, where X-rays are unhelpful and blood tests often normal. And he or she has to use their clinical acumen or their sixth sense to decide whether that patient needs a rapid referral. For the 2-week wait system for patients where the GP suspects or wishes to exclude cancer, set up some 15 years ago, has been a huge help to GPs and to patients. However, there needs to be an obvious referral route, as has already been mentioned, for it to be effective. And in the vast majority of cancers, this is fairly obvious. But with pancreatic cancer and some other rarer cancers, where the GP has concerns but no diagnosis, it is very hard to know to whom to refer. And there are a number of things that could be done, both in hospital and primary care, quite simply, that might lead to cases of pancreatic cancer being diagnosed early. Firstly, like everyone else, I think that if GPs had easy access in consultation with their radiological colleagues to upper abdominal CT scanning, they would be able to make fewer, more effective referrals into the 2-week wait system. Secondly, my view is that all trusts should be obliged to have a named consultant to lead a 2-week wait clinic for referrals where the GP has a high index of suspicion but no diagnosis. and a nebulous serious disease clinic, if you like. And in the absence of the old-fashioned general physician position, which is now quite rare, it would be sensible perhaps if this role was led by a gastroenterologist, although it would be for a trust to decide that. However, such a clinic should be extremely well publicised to all local GPs. Thirdly, our GP practices need to ensure that this category of patients, the hard to diagnose who could have something serious, does not get missed within the practice. And Rosie's presentation has sort of outlined a very sophisticated new tool, which I'm sure will help here, but it could be done quite simply if within a practice, if there was a flagging system where it became practice policy to flag if a doctor, it might just be a locum who comes in once and happens to see the person, has an inner concern that this person may have something serious amiss. Because this is the nub of the issue from the GP's perspective. And finally, GPs need regular updates and reminders, and maybe the charity sector has a role here, though it is well known it can be hard to access very busy GPs. And the new revalidation process is directly linked to GP appraisal, and GPs are funded for having palliative care and significant event meetings, so perhaps it should be possible to arrange for practices to have an annual review of the diagnosis of their new cancer cases, and for that to become an annual event, which would then routinely be discussed by the GP at their annual appraisal to ensure that they are keeping abreast of the whole question of thinking about the diagnosis.